Hi, everyone. Thank you for joining us. I'm Dominique Bossard, Game Plan Advisor at Canadian Sport Institute, Ontario. Welcome to CSIO's webinar series, Podium and Parenthood, Fertility and Family Planning. And today's topic, Fertility 101, Understanding the Basics, brought to us by Markham Fertility Center. At CSIO, our purpose is elevating people and performances, both on and off the field of play, beyond training, and holistically as people first. As athletes stay in sport longer through childbearing years, it's important that you're informed about your options around family planning. As part of CSIO's newly launched Women's Health Initiative, CSIO is keen to welcome Markham Fertility Center as a community partner to ensure athletes have the information they need to make informed decisions. We thank Markham Fertility Center for their willingness and enthusiasm to go deep on the subject of fertility and family planning and share their expertise with high-performance athletes, coaches, and the sport community. For today's session, I'm very pleased to welcome Dr. Marta Wise. Dr. Wise is Quality Director and co-owner of Markham Fertility Center and co-host of My Fertility podcast. She's committed to providing all her patients with comprehensive, person-centered care. Dr. Wise is also an impassioned advocate for women to empower themselves with knowledge about their own fertility and their options for family planning. Thank you so much for leading us in the webinar today. Over to you, Dr. Wise.
Thank you so much for that lovely introduction. I am super pumped to be here and to kick off this really, really exciting series of webinars that we're going to be hosting. Today, we're starting a really basic Fertility 101. So we're going to be focusing on the basics of fertility, and then we're going to be getting into some more detailed stuff. Now, Fertility 101 can mean so many different things, and there are so many different avenues in which to take this. I know that there can be a lot of misconceptions, old wives' tales, questions out there about fertility. So I would love to be able to do some myth busting tonight as well. All right, so let's get rolling. Okay, so a little bit about us. Markham Fertility Center, or MFC. There are 5 physicians. Yes, I know the picture has 4. We have to update. We are all fertility trained physicians, meaning that we've done 5 years of residency in obstetrics and gynecology, an additional 2 years of training specifically about fertility. We're a physician-owned clinic and a physician-run clinic, and we do all the things, meaning IUI, IVF, donor egg, donor sperm, gestational carrier. Again, not all clinics do. We also provide early pregnancy care, seeing patients till at least about 12 weeks of pregnancy. We have 3 full-time genetic counselors on staff to help us talk about some of the more intricate details of genetics and fertility. All of our patients undergoing egg retrievals have deep sedation with anesthesiologists, and we are the only clinic in Ontario that does that. So all of our patients are super comfy. We have multiple affiliates, so Dream Fertility in Oshawa, Horizon Fertility in Aurelia. We have just opened a satellite clinic in Barrie, and we're currently in the process of opening another satellite clinic in Sudbury. So we are working to expand our footprint in Ontario so that we can provide care to more patients closer to home. We really like pink. I don't know if you can tell. One of my colleagues, Dr. Garcia, and I, we launched a podcast. We talk about it all the time because this is really our passion project. This is our baby. We release a new episode every week. We've been doing it for over a year. You can find us on Amazon, Spotify, Apple Podcasts, and lots of great information out there, lots of patient stories as well, general fertility information there as well. So please check us out. Okay, so what is quote unquote normal fertility and what is infertility? What does that really mean? We're going to talk about how to optimize natural fertility. We're going to be talking about some common fertility challenges. So why are people having difficulty getting pregnant and when you should seek help, when you should see a doctor? We're going to talk a little bit about the first fertility appointment, demystify that, if you will. And we're going to talk about some of the initial testing that we do and why we do that. I wanted to get into a little bit of a review about fertility treatments in Ontario, what's available, what things look like, and to get some general ideas around costing and government funding around that. Okay, so what is natural fertility? What we're talking about with natural fertility, we're talking about a couple, a person with sperm, person with eggs, and their ability to conceive a pregnancy without medical assistance via regular, unprotected sexual intercourse. So, what does that mean? Like regular intercourse. So, that can mean different things to different couples. But what's important to keep in mind is that really, if you're having unprotected intercourse with somebody, you are trying to get pregnant. Some patients may sort of make a distinction between trying, quote unquote, versus not trying. But really, it's about unprotected intercourse. You're essentially trying to get pregnant on a somewhat regular basis. To conceive naturally, you need a lot of things. There's a lot of stuff that has to come together and has to work together. There has to be normal reproductive systems in both partners. So we need healthy eggs, we need healthy sperm, we need regular, somewhat predictable ovulation, right? Again, that's that egg coming from the ovary, kind of popping into the tube saying, sperm, come get me. We need open or unblocked fallopian tubes because, again, that's where the egg and the sperm are meeting. And we need a receptive uterus, meaning that the uterus has to be, quote unquote, sticky to this early embryo because the embryo has to stick to it. Now, this is influenced by a bunch of things, right? Age, so age of the person with sperm, age of the person with eggs, hormonal balancing or not balanced hormones, lifestyle factors, overall health, and of course, the timing of intercourse as well. It makes a big difference in terms of whether people are going to conceive or not. So, what is the biggest factor affecting natural fertility? Hands down, it is the age of the egg. This is by far the biggest predictor. When we're talking about the age of the egg, we're talking about the age of the person providing the egg. So often the age of the woman. But just to give you an idea, kind of visualization of why we talk about age so much. So this is a graph showing the relationship of age and fertility. The purple line is the chance of somebody getting pregnant each month with, again, that regular unprotected intercourse. Okay, we're talking about intercourse still. We're not talking about any fancy fertility treatments. On the bottom axis, you can see the age of the woman, and then on the axis on the left, percentage pregnancy per month. On the right side, so that red dashed line is the chance of miscarriage. Okay, so, first of all, what can you see? Number one, as age goes up, chance of pregnancy decreases and chance of miscarriage goes up. If we're talking about somebody who is 32, let's say, the chance of getting pregnant each month for a 32-year-old egg provider, 32-year-old woman, is going to be, let's say, somewhere between 20-25% per month. Okay. The chance of miscarriage is probably around 15% per month. And really at 32, you're still very much at a peak fertility time, right? When we see that purple line, it hasn't really descended very much. Number one, it's very normal for it to take several months to conceive, and that still be totally healthy and totally natural. And again, the risk of miscarriage is 15%. Miscarriages are also very, very common, even in a 32-year-old woman where fertility, we generally regard it as being quite good. Let's contrast that with a 38-year-old egg provider or woman. So at 38, now we see that the chance of pregnancy per month might be, let's call it 10%, 12% per month. So it's like half of that when you're 32. And that chance of miscarriage now has also crept up, and it's probably somewhere just under 25%, I don't know, 22, 23% per pregnancy. So that difference between 32 and 38 years is quite striking, right? And again, we're talking about the person who's providing eggs in the pregnancy. And so that's really why we talk about fertility starting to decline at about age 32 in women. And then as women get into their, let's call it mid to late 30s, we see fertility declining, becoming a much more steep line. And then once a woman is over the age of 40, we will see fertility rates declining. You can see a difference like even every 6 months. And Fertility isn't necessarily reaching zero as a woman's 43, 44, but it's getting pretty close to that number. Okay, but why is the age of the egg so important, right? I know I've hammered this idea of age, but why does this matter? So eggs are finite. When a person with eggs, when a woman is in the uterus, okay, so we're talking about before a woman is born, when she is halfway gestating through the uterus, she's sitting in her mom's uterus at 20 weeks. That's actually when you hit your peak egg number. So when you are not even born, you've already got your peak egg number, which is about 6 to 7 million eggs. By the time she's born, the number of eggs has already declined to 1 to 2 million. So at birth, you're already on the downhill. By the time somebody with eggs hits puberty, they're going to have about 300,000 to 500,000 eggs in the ovary. By the time we get to 37, we now have about 25,000 eggs left in the ovary. Number one, eggs are finite. We do not know how to make more eggs. We don't know how to fix eggs. We just don't have the scientific knowledge for that. Number two, you work through eggs at a much faster number than one per month. When you're thinking about the menstrual cycle, and we think 99% of the time, if somebody has a regular menstrual cycle, they're releasing one egg a month. They're ovulating one egg a month, which is absolutely true. But on top of that, you're also losing eggs. There are also eggs just constantly dying off every day, just apart from that as well. And that's why we're seeing that decline in the egg number. A really, really important concept here is quantity versus quality of the egg. We've talked about age, we've talked about quantity of eggs, but if you're 37 and you've still got 25,000 eggs and you only need one for pregnancy, theoretically, it sounds like pregnancy shouldn't be that hard, theoretically. But this is where quality comes into play, very much so. Quality here. Let's say we take this 37-year-old person again, right? She has eggs, she's 37 years old, and we said she's got 25,000 eggs left. But each of those eggs have now been in the ovary for these 37 years. Over time, they accumulate little bits of genetic damage. We can't really do genetic testing on eggs specifically. We do genetic testing on embryos that result from eggs. That's why now I'm talking about normal embryos as opposed to eggs. But this relates back to the quality of the eggs. If you have somebody who is age 20 to 25 and they make embryos, again, an embryo is an egg and a sperm that have combined together and turned into one entity. You're going to find that about 75% of those embryos are genetically normal. At 35, that number now drops to 50, 60%. By the time you hit 40, you're going to find that only about 15 to 25% of embryos that are created are genetically normal. So with age, we see decreasing quantity and then also decreasing quality of the eggs. What's the deal with sperm, right? I mean, we've talked a lot about eggs here. Sperm is a very different story than eggs. Sperm are produced continuously throughout life. And in fact, kind of every 3 months, there's going to be a whole new cohort of sperm that are present in the testicle. When we talk about age and sperm and age of the sperm provider, that relationship, that graph, it's not really nearly as clear. And so, I mean, we see this in society, right? I'm sure we can all think of celebrities who have fathered pregnancies well into their 60s, even 70s. There is advanced paternal age that we call it. It has variable definitions in terms of who you ask, but certainly we do see some decline in sperm quality once people are hitting over age, let's say 45-ish, but you don't have that clear line, that clear graph as you do with eggs. And so this is why that biological clock that a lot of females may talk about, there is definitely some truth to that. And that's why we talk so much about eggs and egg quality when we're thinking about fertility and optimizing fertility. Switching gears a little bit here, let's talk about infertility. Infertility, the textbook definition is no conception, so no pregnancy occurring after 12 months of regular unprotected intercourse in a heterosexual couple. We talk about primary infertility as being a situation where there's a couple and they've never conceived. They're trying for their first child, let's say. And there's also secondary infertility, which means, let's say, a couple has conceived, maybe they've had a child, and now they're trying for baby number 2, where things used to work and now they're not working. Infertility is very, very common. It's estimated to affect about 1 in 6 couples, or about 15 to 20% of couples. I can basically guarantee for the vast majority of people in this webinar, you know somebody who has experience in fertility, or you're definitely going to know somebody who has experience in fertility, has maybe sought out fertility treatments. In fact, later this month is actually Canadian Fertility Awareness Week. I've got my green ribbon in support of Fertility Awareness Week. So there's going to be a bunch of events going on. And in fact, they're actually going to be lighting up the CN Tower green, I think, on the Thursday night to raise awareness around fertility as well. This is a common question that I get asked a lot, especially at like dinner parties. Is infertility becoming like an epidemic? Is everybody just not able to get pregnant naturally anymore, right? For sure, the prevalence of infertility in pop culture is increasing. We're seeing it way more often on TV. We're seeing it in movies portrayed a lot. We're seeing celebrities talking about their fertility struggles and requiring fertility treatments. Lots of stuff on social media. The fact is that there's so many factors at play, right? Big one, of course, is that society is now promoting more delayed childbearing for a variety of different reasons, right? Whether people are staying longer in school, whether people are seeking economic security before they start thinking about having children, and society is saying, yes, go do the things you want to do, go to school, or obviously get to the podium, and that you can do that and you can still, build a family. But of course, we're delaying childbearing as a result of this as a society as a whole. The other thing is that probably the medical complexity of patients who are planning pregnancy has also increased. We are generally older when we're trying to get pregnant. People have more pre-existing medical conditions. Frankly, like obesity definitely plays a role. And so these things are also affecting fertility rates too. There is, of course, increasing concern around environmental toxins, endocrine disruptors, and what effect these are having too, which is not really so clear. But what's interesting is that in reality, rates of infertility are actually fairly steady when you try and control for these things. I think really it's just we're talking about it more than we ever did. We're thinking about these things a lot more than we ever did. I mean, I think we all have that older relative who never had children, and you don't really know why. Like, it was never really talked about. Whereas now people know the fertility treatment, fertility help exists. People are talking about it. It's way more accepted. If you ever want to see a great movie, I highly recommend watching Joy on Netflix. It's a fabulous movie, basically talking about the first 2 physicians and the nurse. So Edwards and Steptoe and their nurse Jean Purdy, and about their journey with the first IVF cycle and the first IVF pregnancy, and watching how society felt about IVF back in the 70s, like the late 70s, really not that long ago, versus now. It'll blow your mind. And it's a great movie too. We've talked about what infertility is. So when should you consider seeing a fertility specialist, right? So we're talking about seeing people who are having difficulty conceiving. We also see people with recurrent miscarriages. So again, I said infertility, 12 months unprotected intercourse. If the age of the egg provider is greater than 35, or if there is some kind of known fertility issue, or there's some fertility problem, fertility risk factor, you should probably be coming to see us after about 6 months of unprotected intercourse. We also see lots of patients for recurrent pregnancy loss. Recurrent pregnancy loss, now the definition does vary depending on who you ask. 3 or more, 2 or 3, let's say, or more miscarriages happening in the first or early second trimester, that's another opportunity to see a fertility specialist, do some testing, do some investigations to see what's going on. We also do a lot of other stuff. Who else should be seeing a fertility doctor? So if you want to become a single parent by choice, right? If you are in a same-sex couple, patients who are known carriers of genetic diseases in the world of fertility, the classic example, let's say there's a couple and they both know that they're carriers of a genetic condition like cystic fibrosis, meaning the person with the eggs is a carrier, the person with sperm is a carrier. Now, neither of them has the condition because to have the condition, you have to have 2 copies, so one from mom, one from dad, but each of them carries 1 copy. So they know that they have about a 25% risk that if they have a baby, baby's going to have the full-blown condition. We see them pre-pregnancy because we can actually do genetic testing on embryos to figure out which embryos are affected, which are carriers, and we can help also from fertility for that perspective as well. So that's another thing that we do in a fertility clinic. We do a lot of stuff, not just heterosexual couples who are having difficulties getting pregnant. Let's say you are on a fertility journey, or you may be on a fertility journey soon. What can you do to increase the chances of pregnancy? How can you optimize fertility? We want to be smart. We want to be efficient about how we go about things. First of all, let's talk about timing. I find a lot of people get hung up on timing. And we're talking about the timing of intercourse here, the timing of the fertile window. Once you have an understanding of the menstrual cycle, so I definitely highly recommend watching that webinar. But generally speaking, in a 28-day menstrual cycle, ovulation probably occurs around cycle day 14. Okay, so keep in mind a couple of things here. Number 1, cycle day 1 is the first day of full flow of the period. So first day of full flow being cycle day 1. If the first day of full flow to the next first day of full flow is 28 days, ovulation's probably occurring about cycle day 14. The fertile window, so that time when you can get pregnant, is about 6 days ending the day of ovulation. So again, if we're going to do some math here, it's probably running cycle day 8 to cycle day 14 in this 28-day cycle. That is that fertile window. Now, if you are wanting to help track things, there are apps that you can use that will help track cycles and will help you predict your fertile window, help you predict ovulation. One really great app is Flow, like FLO. It's quite accurate, and so it's totally reasonable to use it. It's free. I recommend it. Some people will also try ovulation predictor kits. You can either buy online or go to Shoppers or whatever and get these kits, and they basically are checking your urine to see when you're having a big hormone surge that's going to predict ovulation because it happens in time with that big hormone surge. The ovulation predictor kits are great, especially if the cycles are a little bit irregular, but if the cycles are pretty regular, I mean, it's not going to vary too much, like month to month, cycle to cycle. Practically speaking, if somebody has a 28-day cycle, I would say aim for intercourse cycle day like 10, 12, 14, once per day, to be clear. Every 2 days, more than enough. And that's going to cover you for that fertile window. I would recommend the webinar on the menstrual cycle because it makes a lot more sense, in my opinion. So this is a graph looking at probability of pregnancy by cycle day. So this is days relative to ovulation. So day 0 is ovulation day. Ovulation day is that egg release day. That's when the egg is coming. What you can see is that the chance of pregnancy is probably best a couple days pre-ovulation. 2 days before ovulation, you're probably going to hit the peak pregnancy rates or have the best chances of pregnancy. But really that fertile window, we think about it as being day of ovulation and 6 days prior or -6. The other important thing to keep in mind is that healthy sperm will survive for 5 days in the female reproductive tract as well. That gives even more, kind of opens up the fertile window a little bit too, right? That you don't have to be hitting like exactly 2 days before ovulation. Again, if the sperm gets there a day or two early, it's going to hang out for 5 days. It's still going to be around when the egg is there. So the timing is good. Although timing is important and something to keep in mind, it is not the be all and end all of fertility. It's not like the movies. We've all seen those TV shows and the movies where it's like, you know, the man gets a call that like his wife is ovulating. He like rushes home and they have to have intercourse. They have to drop everything and do it in some linen closet, broom closet in the mall because like she's ovulating. Okay, it's not like that. I'm not condoning that behavior, just for the record, please. Okay, so other ways to optimize fertility. Let's talk about sex. For the record, no question is off limits here, please. Common questions I've been asked. Does position matter? No, it does not. Specific timing, meaning like, whether it's better in the morning or in the afternoon or in the evening, it does not matter. Whatever time of day is most convenient, whatever works for the people involved. Post intercourse, what do you do? I think this one comes from movies, the idea that the woman is going to lift her legs up post intercourse because that's going to help the sperm get to where it needs to go. That is not true. Think of it this way. With ejaculation, the sperm is in the vagina and it's got to get through the cervix to the uterus. Even if you lift your legs up, you're not actually moving your pelvis. This doesn't really do anything. You're literally just moving your legs, maybe, I don't know, having a nice stretch. So not necessary. Putting a pillow under the hips does not make a difference either. Honestly, the vagina is very acidic, and it's good that it's acidic. It needs to be acidic. Otherwise, you're going to end up with a yeast infection. But vaginas are acidic. Sperm don't like it. They die off really fast in the vagina. Sperm have to get in and get out ASAP to be able to survive. And so from ejaculation to the sperm getting to the fallopian tube, it has to be like 5 minutes, basically. They have to move really fast to get to where they need to go. Sperm are very athletic, and they definitely make it to the podium. It's my little athletic joke. Okay. Frequency of intercourse. As I said, every 2 days is more than enough. If the male partner has a normal semen analysis, normal sperm parameters, which we'll talk about. Another question I get asked a lot about is about saving up sperm. It's this concept that the person with sperm does not ejaculate until the fertile window so that they save up lots of sperm so that when intercourse does happen, that there's lots of extra sperm around. This is actually negative. I would most definitely not recommend this because what happens is that, you have lots of sperm, but there are lots of dead sperm. They're stale sperm, if you want to think of it that way. So actually, when we're doing IVF, when we're doing IUI, we want fresh sperm. Our lab always says fresh is best. You're going to get the best quality sperm with ejaculation every 2-3 days, actually. So there's absolutely no need to save up sperm. Lubricants are totally fine when a couple is trying to conceive, but it depends which lubricant. I would stay away from the Astroglide, KY type lubricants because they are not good for sperm. They will prevent the sperm from swimming. There is a fertility friendly lubricant called Pre-Seed. I haven't really seen it so much for sale like in stores. You can definitely order it online though.
Dr. Wise, there's a question in the
Oh,
Q&A
please.
chat. It says, is low sperm count genetic?
Oh, good question. Okay, maybe is the answer. Sometimes it is. There are certain conditions that we know that people will have a low sperm count. Males have XY chromosomes, females XX chromosomes. So the Y chromosome will have the genes that are responsible for sperm production. And so there are some men who will have deletions of parts of the Y chromosome, very small deletions. So they are healthy. You would never know, they've never had any health issues, nothing. But then when we do semen analysis, they'll have extremely low sperm counts. That's like a known reason. Sometimes there can be people who have an extra X chromosome. So if somebody is appearing male, has a penis, all the male secondary sexual characteristics, but then when we go and we do a semen analysis, they may have no sperm at all, zero sperm. But when we're talking about a low-ish, lower sperm count, we don't necessarily have great understanding of the genetics for sperm counts for many conditions, only very, very specific examples. So that's why I said maybe. There's definitely a lot of research into this area, and there's definitely a lot of interest in that area for sure. Lifestyle stuff. So, alcohol, bad. Smoking, bad. Cannabis, probably bad for eggs and sperm. Caffeine. So for the person carrying the pregnancy, consuming large amounts of caffeine leading up to pregnancy and in early pregnancy may potentially increase risk of miscarriage. And so that's why we often recommend limiting it to one small coffee a day. Sleep is also important, looking for 7 to 9 hours of sleep to optimize chances of pregnancy. Weight, of course, not just being overweight, but being underweight can also have a significant impact on hormones, which can also have significant impact on ovulation and the menstrual cycle and getting pregnant. Now, a prenatal vitamin, let me be clear, like a prenatal vitamin does not help you get pregnant. It does not fix infertility. However, they're super, super important for optimizing the health of the pregnancy. Prenatal vitamins should contain at least 400 micrograms of folic acid. And you should be taking a prenatal vitamin, ideally, for at least 3 months pre-conception to get the biggest benefit in terms of reducing risk of birth defects in babies, specifically neural tube defects, which includes things like spina bifida. If you are at all in the, let's call it fertility social media world, there's so much talk about folic acid and which folic acid and, active folic acid, not folic, active folic acid. I'm not going to get into it because honestly, that's like a whole 45-minute topic on itself. But Dr. Garcia and I have recorded a podcast episode specifically talking about prenatal vitamins and what you should look for in your prenatal vitamins and the evidence for why. So you can definitely check that out. Please consider a prenatal vitamin. We also talk about medical optimization of medical issues, the other things going on, considering other potential fertility issues, maybe making sure vaccinations are up to date. So things like chickenpox, measles right now, rubella as well. Why do people have difficulty getting pregnant? I mean, there's so many different reasons. It can be a combination of reasons as well. This I pulled from the textbook. This is like the Bible of fertility for fertility physicians. We have couples on the left, and when you're looking at women specifically on the right, for couples, male fertility can account for 35% of fertility issues, but unexplained infertility is also, again, 10% here. I would actually argue unexplained infertility in our kind of common Canadian patient population is actually much higher, maybe even like 20, 30%. So we don't necessarily always come up with a great reason in terms of why couples are conceiving. But I always tell people, even if you have unexplained infertility, it doesn't mean that we can't help you, just that we're not exactly sure what the issue is, but we can still absolutely help you build the family that you are hoping to have. Let's say you come see a fertility doctor. We're really not that scary, in my opinion. We're going to talk about your periods. We're going to talk about sex, obviously. We're going to talk about previous pregnancy history, if there is anything, medical history, surgical history. We're going to talk about lifestyle stuff. So we always ask, alcohol, smoking, cannabis, that kind of stuff. We might talk about BMI as well, just sort of thinking about optimizing that too. But really, it's a lot of talking. And we always want to talk about the goals and desires. Like, are you somebody who wants to have kids now? Are you hoping to have kids in the future? Are you hoping to have one child? Are you hoping to have 4 children? How are we going to plan for the big picture? Initial testing, also not scary. For people with sperm, we're going to do blood work. We're going to talk about doing a sperm test or a semen analysis. For people with eggs, we're going to talk about blood work, thyroid. We're also going to do some ultrasounds to assess the uterus and assess the tubes. I really wanted to bring up AMH just because this does come up as a fairly common question that I get from patients in terms of, I've heard about this blood test, an anti-Müllerian hormone. I've been told that it can tell me if I have fertility or if I have infertility or if I can get pregnant or if I can't get pregnant. Okay, so that's not exactly it. AMH does not predict chance of live birth and it does not predict natural fertility. So if somebody comes to see me and they've never tried to get pregnant, I can do testing, but I can't predict whether you're going to have infertility in the future or not. AMH is a great test for me because it helps me figure out what dose of medication somebody might need during IVF, helps me set expectations in terms of the number of eggs I think I'm going to get, whether we're freezing eggs or whether we're doing IVF. And it helps me counsel people when we're thinking about fertility preservations around egg freezing as well. But again, does not predict live birth, does not predict natural fertility. But it's kind of like the best test that we've got in terms of fertility testing. Semen analyses, I wanted to bring up just because this does tend to cause some anxiety for people. We typically do the assessments in the clinic. That being said, people can produce the sample at home and bring it in. Okay. We're looking at the sperm count. We're looking at motility. We're looking at the appearance of the sperm, the morphology as well, covered by OHIP. So just wanted to briefly kind of give you an idea about fertility treatments. I mean, again, there's going to be a whole webinar about this. So it's pretty wild when you think about it, in my opinion. In 2022, there were almost 42,000 cycles of IVF that happened in 33 clinics across the country. And over 12,000 pregnancies resulted just in 2022 from IVF. And to me, this is wild because the very first IVF baby was born in 1978. And that's her, Louise Brown. And that's a very recent picture of her. It's wild how far we have come from 1978 to now. And so she's holding actually the very first incubator where she started out. Just being mindful of time here, I'm going to skip over overview of fertility treatments here. I wanted to talk a bit about fertility care in Ontario. Again, there's going to be a whole webinar about this. But it's important to keep in mind, number one, costs are highly variable depending on what people are doing. Some things are going to be covered under OHIP, to your health card. Some things are not going to be covered under OHIP. And not all clinics have the same levels of OHIP coverage or funding. So if you go to, let's say, one clinic, they might not have any government-funded IVF cycles at all. If you come to a different clinic, like let's say Markham, we have a good number of government-funded IVF cycles, and our patients are able to access that. There are some clinics that don't have government-funded IUI at all either. And so you might be paying, I've heard, $1,500 for an IUI, whereas we have government funding for IUI, so maybe paying more like $600, $650. It is worth it to really think about things and to think about the clinic, right? It's not like seeing another medical specialist in Ontario where you kind of assume you're going to get something like really similar across different clinics across the province, but that's not the case at all. This is the same graph that I showed earlier, right on the left side with age and with miscarriage rate. On the right is similar axes, but this is looking at IVF success rates. The exact numbers aren't too important, and the data on the right is from 2010, so it's a little bit out of date. But I want to show that really, although we've got IVF, and IVF is awesome, and we have fertility treatments, and they're great, and we are getting lots of people pregnant who may not have been pregnant otherwise, age is still really important, right? And that when you're doing IVF, let's say in your mid to late 30s, those pregnancy rates are going to be lower than if you're doing it earlier on. And those miscarriage rates are going to be higher, right, if you're doing it later in life. So again, that 32-year-old woman, that pregnancy rate, chance of pregnancy on the left, IVF pregnancy rate on the right. And then again, contrasting that to the 38-year-old woman. So, IVF pregnancy rate might be, let's say 40%. Probably now I would say at 32, it's more like 50, 60%. But at 38, it's going to be lower, maybe 30 to 40%. Conclusions. Natural fertility varies with so many factors. Some we can control, some we can't. Consider fertility help after 6 to 12 months of trying, or if you are falling into one of the other conditions or one of the other reasons why you may be coming to see a fertility clinic. There's also lots of fertility treatments out there. And again, they vary in terms of success rates, their costs, the clinics, etc. So really educate yourself and really think about these things rather than just going to a random clinic. And at the end of the day, knowledge is power. Although the data, the info can be a little bit scary sometimes, it's better to think about it sooner rather than later. It's better to think about fertility sooner rather than later, and to have those conversations and to think about what that can mean and what your life can look like, and to think about things that you can do to optimize this chance of success so that whenever you are ready, to build a family, your odds of success are going to be good. Because at the end of the day, we all just want you to be building the family that you've always wanted to build at the time that's ready for you, right? Knowledge is power. That is the end of my slides.
Thank you so much, Dr. Wise. We're going to jump in with the Q&A. There are some that are queued up already.
Awesome.
First up, what if you have historically an irregular cycle? How can you track the fertility window? And is irregularity a sign of potential fertility issue?
Irregularity can mean a lot of different things. So there can be irregular, like my cycle 1 month is like 28 days and then it's 29 days. So that's sort of very not so irregular versus I have a period every 3 months, or I really have no idea when my period is ever going to show up. In situations where somebody has an irregular cycle, that can make it more difficult to conceive because that ovulation is going to be a lot less predictable. So knowing when your fertile window is really, really hard. Certainly I wouldn't be able to predict off the top of my mind or sort of by the calendar. And if you are ovulating, they are going to be much more spaced out. So let's say over 12 months, if your periods are coming every 2 months, let's say, you might have 6 ovulations or 6 chances of pregnancy. Whereas if your cycle's 28 days, you might have 13 chances for pregnancy, right? That can be a fertility issue, let's say, or can decrease fertility. So reasonable to try naturally for 6 months and then see a fertility specialist. Because again, we have ways to kind of kickstart ovulation to get it happening in a more frequent, more predictable, and more regular way. Maybe we combine that with intercourse, let's say, and then we're kind of restoring your natural fertility.
Great. Next question. If you are currently on IUD contraception impacting your period, how long would it take once removed to return to your original cycle?
With the IUD, once it's out, honestly, it's like a month. It's very, very fast that the fertility will come back, especially if you've had the IUD in for a while or if it's a non-hormonal IUD. So fertility gets restored quite quickly.
Great. Next question, and I believe this pertains to the low sperm count in males section that you discussed. Are there any concerns if the male is XYY?
That can potentially affect sperm counts. It's not common at all, but that can also affect the genetics of the sperm that are coming. So that'd be a good reason to also see a fertility clinic and talk with a genetic counselor as well.
Great. Next question. What options are available to conceive when there is low sperm count?
So it depends on terms of how low is low. When we think about conceiving, let's say by intercourse, by IUI, by IVF, to get the optimal chance of pregnancy, the sperm count has to be at a certain threshold, let's say. That sperm count will help us steer us, predict sort of what fertility treatment a person might need. So if it's like a tiny bit low, then maybe IUI will work because that's giving the sperm a little head start. If the count is really, really low, then sometimes we need to do IVF because the chances of pregnancy by IUI or by intercourse are sub 2%. So it really depends on what that absolute number is in terms of what the treatment should be or could be. I'll also say one sperm test is not the be all and end all of life. What I mean is sperm are highly variable over time. So for anybody with a low sperm count, I will always repeat the sperm test before we plunge into anything to see whether it's a one-off or whether it's a pattern of more consistent, the pattern of numbers that we're seeing.
Perfect. The last question that I'm seeing in the chat currently, this one refers to the slide with pie charts on causes of infertility. Is there any preemptive screening available to find out if you might face those in the future, even if you're not currently trying?
That's the really hard one because even if you come to a fertility clinic and we do the standard battery of fertility testing, it's going to be a really, really poor predictor of whether you're going to have fertility issues or not in the future. Because I will see a patient, let's say has infertility. So they've been trying for a year with a partner with sperm, and we'll do all the testing, and all the testing comes back totally fine, right? And that accounts for probably 30% of patients that I see where the fallopian tubes are open, uterus looks good, AMH, let's say that egg reserve is sort of normal for that person's age. There are so many fertility issues that we can't quite pinpoint. I tell people we can count the sperm, we can check that they're swimming. But how do you actually know a sperm can fertilize an egg? Like actually do the thing, right? There's no test for that really. You know, you can check egg number, but there's no test for egg quality, right? So I said, okay, at this age, this is the expected age quality, but what is your egg quality? There's no test for that. I talked about the uterus being sticky to an embryo. We can look structurally to see if there's stuff going on in the uterus, like structural stuff, but there can be immune issues. There can be other receptivity issues that we don't really have great testing for, right? There is no testing that can really predict whether you can get pregnant or not in the future at some point, unfortunately.
Okay, and one more question just came through. Are there any concerns if you have a cycle shorter than 28 days?
Depends how short it is, but many people will have a cycle that's shorter than 28 days. The menstrual cycle has two phases. There's a follicular phase, ovulation, and then the luteal phase. The luteal phase, so those second 2 weeks, is generally very set, and it's always about 14 days. The shorter the cycle, the more the day of ovulation moves closer to day 1, let's say. So that follicular phase shortens. In a 24-day cycle, let's say, you might be ovulating cycle day 10. So it just means that the fertile window is shifted over. You have to account for that when you're thinking about fertile window and timing of intercourse. Again, if the cycles are short but regular, an app like Flow app, whatever, will be able to account for that.
Perfect. Those are all the questions that are currently in the chat. So I will turn it back over to you and to Dominique.
I just want to say thank you so much for everybody joining us today, and Dr. Wise and the Markham Fertility team. Like, thank you so much for such a wonderful intro to fertility. And again, for your commitment to sharing such important knowledge with our athletes and sport community and going really deep with the 6 sessions. I think that's really amazing. I also want to highlight my fertility podcast, which we will share the link for that as well. Dr. Wise, thank you so much.
Oh, my pleasure.
Thanks,
Awesome. Thank you
everybody.
for having me.